We're going to start out with introductions. I'm Dr. Marta Becker. I'm going to be our moderator today for our discussion of the intersection between chronic condition and women's health. Just for ways of introduction, I'm a private practice otolaryngologist, which is an ENT doctor, and I work in Philadelphia. But I'm very interested in the ways in which technology can help us improve the doctor-patient relationship and how that communication can lead to better outcomes for patients. And one of the reasons that we are focusing on women's health and chronic conditions today is that those are two populations, both chronic condition patients and also women who can get the short end of the stick a little bit when it comes to their healthcare experience. So Tracy and I, who founded Journal My Health, are interested in understanding a little bit more about ways in which we can improve patient experience. And we thought this was just a great topic to get more information for everybody about. So we have a bunch of panelists who all have really great perspectives on this issue. And I'm going to go around and let you guys introduce yourselves one at a time. I'm just going to go in order of my Zoom screen. Okay, so in no particular order. First, we'll just let Dr. Sellers go ahead.
Hi, everybody. So my name is Jason Sellers. I'm a family medicine physician, and I'm currently the medical director at Radish Health. And we're providing primary care through telehealth to our patients. My background is actually in biomedical engineering, but I left that and then went on to go to medical school and did my training and my medical school in the Philadelphia area. I'm also really interested in health technology and how that plays out with interactions with patients and just being able to keep in touch with patients and have that kind of close longitudinal relationship over time. So happy to be here and happy to join this conversation.
Well, thank you. And Dr. Milani, I have you next.
Hi, I'm Dr. Roshi Milani. I am a cardiologist at Staten Island University Hospital under the Northwell Health System. I specialize in prevention and women's health. So this is a very a topic that's near and dear to my heart. And I also am interested in technology and how it can improve the care we provide and how patients care for their own chronic conditions too.
Great. And Dr. Schmerling, you're next on my screen.
Thank you. I am Allison Schmerling. I am a family physician as well. I am also the medical director for Isla Health, which is a virtual care company providing longitudinal and coordinated care for patients with autoimmune and complex chronic conditions. And in my life before this, I was a broad scope spectrum women's health provider with kind of areas of concentration in perinatal care, pre and postpartum, and then caring for complex patients with lots of symptoms and not a lot of answers is kind of my favorite patient population. So I'm also very excited to be here today, very excited to think about how, especially for patients of, childbearing age, working age, caring for families, how can we make healthcare more accessible to them? And I think technology is a great way for us to do that. So thanks for having me.
That's great. Thank you. And then Dr. Joe Kakady Monzo is next, and she sometimes goes by Dr. Joe.
It's just easier. Okay, hi everybody. I'm an obstetrician gynecologist at Mainline Health, Philadelphia area. Lankenau Hospital is my main hospital. I've been there for many, many, many years. I don't want to say how many because that would make me very old. Delivering babies, doing surgery. I'm also, as of recently, the last 7 or so years, the chairman of the Department of OBGYN at PCOM, Philadelphia College of Osteopathic Medicine, which is also here in Philly. We have a few schools across the country, and I kind of chair over all of that, trying to teach our newest doctors coming out all the great stuff about medicine. I have always been passionate, obviously, about women's health and, doing my part to try to get patients to really focus on how they can prevent disease versus having to be at the point where we're treating the disease, rather when it's, whether it's a GYN problem, whether it's a cardiovascular risk that they have, whether it's an autoimmune disease that they're dealing with and struggling with, we kind of watch over women and try to keep them healthy and try to prevent all of these things that happen, especially, as we age.
Cool. Well, just to get into it then, I guess, I was, just for our listeners, I think one of the things that motivated us to come together and talk, like I said, is this idea that there's a kind of an interesting intersection between, women's health and women's, both their bodies and also their, psychosocial environments that create a specific set of health challenges for women that are often overlooked in things like clinical trials or even, data about prevalence of disease and things like that. And so I guess, we wanted to get some perspectives from different people. I think all, women are half the population. And so primary care physicians are going to be the first people that women see, or sometimes, the only people, unless they have, childbearing issues or things like that, for their health care, if they're very healthy. So the primary care physician's, going to be probably the one with the most experience, right, in treating women's issues, just because they treat everything. So I wanted to ask our primary care physicians, and maybe we can start with you, Dr. Sellers, like, what are some things that you feel are unique about women's healthcare? What are some conditions or issues that you see women bringing to you that you would want people to be more aware of?
Yeah, so certainly, like you said, the primary care doctor, the role really is to be the go-to person, right, for care for everybody. So, women will come to us with any medical concern, whether it's preventative health, whether it's a chronic condition, whether it's an urgent care need or whatnot. And the role of the primary care doctor, in my mind, is, on one hand, being able to deal with the medical issues, but also being able to help out with the day-to-day things, the home and work life, and the diet and exercise, sleep, mental health, which are all things that don't necessarily seem outwardly medical, but have a huge influence on overall health and well-being for my patients. So to answer your question about, some of the things that we see more commonly in women, the diversity is very broad, and there are tons of things that we could go over. I would say just on a day-to-day basis, we see a lot more mental health concerns, anxiety, depression, eating disorders that tend to occur more frequently in women than in men. A common one in the primary care scope is UTIs. Urinary tract infections are one of the biggest things that we treat on a day-to-day basis. And then women are also more likely to have negative health effects from some of the other things that we treat, on a regular basis, whether it's from, sexually transmitted infections all the way to heart disease. And then especially as women get older, they're also more likely to develop certain conditions. Stroke is more common as women age than it is in men. Osteoporosis is something that is, by and large, a women's disease, a women's condition. And that's, thinning of the bones or decreased bone mineral density, which can lead to bone fractures over time. And then, even if you're just looking across all ages, things that we see, migraines are more prevalent in women. Thyroid disease is more prevalent. Irritable bowel syndrome is another one. And then there's a whole host of autoimmune conditions from, lupus, rheumatoid arthritis, chronic fatigue. So there's really a lot of things that touch women differently than they touch men. And, we're, taught in medical school that, these conditions are all more common in women, but rarely we're given the explanation, why is that the case? And what is it about the biology of women that cause these conditions to be, more common for them?
And as far as I can tell, that's pretty much understudied, wouldn't you agree?
Yeah, certainly. Absolutely. Yeah. But
What is it?
I don't think we certainly don't have all the answers.
Well, I'm gonna use that as a segue actually, to let Dr. Schmerling talk, because I think if anybody on the panel, she might be the best one. I mean, a good one to address that question. Why do you have any thoughts or what do people say about why some of these things are more prevalent in women? Dr. Schmerling, what do you think? I'm putting you on the spot.
Yeah, no, that's okay. Yeah, I mean, I think, there are a multitude of factors that could be contributing. I think one of them is, kind of women's hormonal cycles and fluctuations can definitely, exacerbate or relieve symptoms in some people. Sometimes we see pregnancy is kind of a great stress test for the hormonal impact of, somebody's hormones on their health. Sometimes about a third of autoimmune diseases will get better, a third stay the same, and a third get worse. And so, we know that hormonal change definitely plays a role. We also know that women, metabolize medications differently. Their percent body fat is higher than it is for men. And so the kind of pharmacokinetics and how a medication might be processed by a female body is going to be different than it is for a male body. And then I think, just the lack of research, not having had, decades and decades and decades studying women specifically, and just kind of lumping, women into a group and looking at those outcomes, all collectively, I think has definitely hurt our ability to know why, women sometimes have different presentations. And then just like Dr. Sellers said, the autoimmune disease is 80% in women. So definitely way more prevalent. And so there is something there about how, the body kind of creates autoantibodies that is just more common in female bodies. I don't know that we have all of the pathophysiology on that quite yet, but definitely something we're still learning about.
Would you say too, I think, Dr. Sellers did kind of touch a little bit too on the idea that there's even things about women's roles in the family and roles in society that may affect our health as well. Like, maybe there's, an understanding that we may process our emotions differently than men, or we may feel more responsible for the care. We may be more involved in the care of both our children and our parents and our siblings than men, and that that there may be like psychosocial stressors as well that are part of women's lives that affect their health.
Yeah, I mean, I think we do often see that women are putting everybody in their life first and tend to, put off getting care for themselves. I think that is something we commonly see. I think, seeing depression and anxiety more commonly in women is sometimes a double-edged sword. If you look back at medical history, the words hysterectomy and hysteria, are kind of always female attributed words. And I think we tend to be quick to place a lot of female symptoms on things like mental health diagnoses when, often there is an underlying reason. And sometimes it is just overwhelming stress and, overwhelming burdens in their home or in the workplace. But then I think there's also a component of, maybe there is something going on and we, do have to listen to really what women are saying and take their concerns, seriously, make sure we're ruling things out. Things like stroke or heart attack are going to look different in a woman and might look less severe. And so making sure that we really are, acknowledging that, yes, sometimes depression and anxiety is more common, and so are lots of other things. So making sure that we kind of consider both.
Yeah. And so so along those lines, can you give advice for people? Say you're struggling with an undiagnosed bunch of symptoms, and maybe somebody said, oh, it's in your head, or you're just stressed, and maybe some other doctor has done a test or two and they've been negative. Can you give advice for people, since this is sort of what you do, who are struggling about navigating the healthcare system and how they can coordinate their care and be heard?
Yeah, absolutely. So I think that's something we see really, really commonly. And I think, I have a couple pieces of advice for this. One is keep track, track what's going on, track the doctors you've seen, the tests you've gotten, the images you've gotten. Unfortunately, although I think we're moving towards a better healthcare system, things are very fragmented, and the doctor you see in one office might not know what a doctor in another office did. So, really try to keep track of that as best you can. And I think, tracking apps like Journal My Health or, Isla Health app are great places to do that. And then, thinking about other ways that you can find the right provider. I think from my perspective, a patient's symptoms are always real. That is a subjective thing. It's what the patient is experiencing. I'm never going to tell a patient you're not having that symptom because they are having that symptom, not me. And so I think finding doctors that will listen to that and acknowledge your symptoms and say, you know, sometimes we're not going to have a diagnosis today or tomorrow or in a couple of months, but we can still work with you and get you feeling better. And that's really, I think, the goal of your care team is to get you feeling better, even if we don't always have answers. And I think that's my third piece of advice is just, you know, acknowledging that sometimes doctors aren't going to know the answer, and doctors are trained to treat things. They get very frustrated when they don't have an answer, and it's not because they're frustrated with you, but they're frustrated that they can't solve the problem because that's what they were trained to do. So I think, you know, being willing to be flexible, patient, collaborative with your team is a really powerful tool. And then if you're not being heard, find a doctor that will listen to you, because there are lots out there that I think, you know, could be a really great fit.
That's great. That's great advice. And again, like, I feel like you guys are giving me these great segues and like doing segues and doing my job for me, but it does bring us to sort of this, you know, question about times in women's lives too, where things are changing for them. And I was hoping to get some GYN input on what are some roles of women's hormones, and not just their menstrual cycle, but also when they start their period and when they finish their period. What are some ways in which our bodies can change, and ways in which these hormones seem to affect our other symptoms or chronic conditions? Dr. Joe, do you want to take a crack at it?
Sure, absolutely. You know, it's so interesting because over the years, many years that I've been talking with women and treating women and trying to help with whatever situation presented, there is just so much to this. And Dr. Schmerling brought up some great ideas about how to be your own health advocate. You know, I need you to write down your symptoms. I need you to put them down so that you don't leave my office and say, oh my gosh, I forgot to tell her this. Right. I love when people come in. I mean, I have a mainline practice. My patients come in with internet articles and they're like, Dr. Joe, can you tell me what you think of this? Be careful. There's a lot of apps out there that are phenomenal. There's thousands and thousands of these apps now that can help you, like yours, with figuring out what's going on with your health. So number one, be your own advocate, because medicine right now is great, but you know, there's a lot going on, as you guys know, and some people are rushed and some people are not, you know, making sure that they're taking the time to listen to what you're saying. So you want to be with someone who listens to you, number one, and you want to be your own advocate, number two. And, you know, as far as hormone milieu through your life, it's just changing constantly, right? It depends on when you start your menarche and start your menstruation and how long you're in those premenopausal fertile years. And then what age you are when you go through the perimenopause and enter menopause. What your estrogen life is like, how many babies have you had, how many ovulations have you had, were you on oral contraceptive pills? I mean, I could talk for days and days about this. Estrogen is one of my favorite things to talk about, because people talk about estrogen and sometimes they're being nice to it, and then sometimes they're being very mean to that hormone, you know, and it depends on what part of medicine you're talking about, whether you love estrogen or you don't. There are some phenomenal things about the hormone estrogen, and then there are some things that aren't so great, right? And a lot of that is very confusing to people, right? Like just last night, I was in an event that was supposed to not be medical, but the conversation went to, well, I've been on a pill for 10 consecutive years, oral contraceptive. And what does that mean for me later? Maybe I should come off of it because I'm worried about my fertility coming off of it. I'm worried about cancers after I come off of it. And it's amazing to me how much misinformation there is out there about some of these things. So I would say just read and know from your doctors what you can expect, right? So when I have a female who's 49 and her periods have started to get irregular, and she comes in and says to me, you know, I'm starting to have a little bit of this and a little bit of that and a little bit of this and a little bit of that, you know, I give them the story. Okay, here's what you can expect. Some people have this and others don't. You may be in here with symptoms of, you know, vulvovaginal atrophy, vasomotor symptoms, having lots of hot flashes. Some people have none. Some people, it goes on for years. Everyone is different. And as a physician, you have to continue to remind yourself that everyone out there is an individual. And I teach my students, I teach my residents, you cannot look at any two patients the same. No one is the same person. And everyone has their own set of issues. Cardiovascular disease risks. I have patients who come in, they're not even thinking about cardiovascular disease risks, right? And they need to be, because Dr. Milani is going to be the one to tell them, here are your 7 modifiable risks, and here's what I want you to do. So I push them as an OBGYN who is both primary care and specialty care, right, for women, to see their cardiologist, especially when they become perimenopausal and menopausal, because our risk goes sky high, right? And what do people die of in this country? If you ask women what people die of, they'll tell you breast cancer. I show them a pie chart and I show them, this is not what you die of. You're going to die of cardiovascular disease. So this is what I want you to focus on, guys, right? Because it's so important, especially when they get into their menopausal years. But a lot of women come in, you know, earlier, and they're worried about fertility, and they're worried about, should I be on this pill? And there's just so much about your hormone milieu, and it is integrated with every other part of you, right? Metabolically,
Yeah.
and mental health and everything. So, you know,
So
be vocal.
So I think it's a great, again, like you brought up the cardiovascular disease, and I know, you know, there's been more publicity about, you know, women's heart health in recent years, but I think that the public doesn't understand, you know, we think of like these men getting heart attacks, and people may not be as aware that our hormones affect our cardiovascular health as well, and that there are issues with, you know, estrogen and cardiovascular health. And it's a great segue for Dr. Milani to kick in on her perspective as a cardiologist on these issues.
Thanks so much, Marta. Dr. Joe, you set me up perfectly. I actually, for the most part, I really think most women they actually probably don't even have a PCP. Their OB is their primary care doctor for years and years and years. And now as women are having kids later on in life, getting pregnant later on in life, and actually more women are using fertility treatments with the high dose hormones, I think that this is where cardiovascular disease actually becomes really important to focus on early on. We now, with more and more studies that are being done on women, we know that preeclampsia, hypertension in pregnancy, diabetes in pregnancy, all are risk factors for developing cardiovascular disease later on in life. And Dr. Joe can talk more about this, but having preeclampsia has significant effects on potentially on the baby, on the woman herself, even after the actual event is over. So I do see women that are considered high risk pregnancies in my practice, even if it's just a talk about, you know, later on, you need to come back and see me. You need to monitor your cholesterol levels. You need to monitor your blood pressure. A lot of times pregnancy-related hypertension does go down after the baby is delivered, but that doesn't mean it can't come back. And these women do have a higher risk of developing it later on in life. So that's one angle of it. The next angle is going to menopause. So this is where estrogen can be good and bad. So estrogen is protective from a cardiovascular aspect throughout most of our lives. However, when the estrogen levels go down after menopause, that's when, you know, the cholesterol starts creeping up. That estrogen used to keep that HDL, which is the good cholesterol, high and at a very protective level, and that level may start coming down. The LDL, the bad cholesterol, can start creeping up over time. The estrogen also keeps blood vessels very pliable and flexible and keeps blood pressure controlled. So as the blood pressure, as the vessels become stiffer, that can create hypertension. So I see a lot of women that come to me and they're like, I was fine my whole life and I never had high blood pressure. I never have high cholesterol. And I'm like, you know, it's really important. That's like one of the questions I ask to all my women patients. You know, when did you hit menopause? Was it a hysterectomy? Did you have your ovaries taken out? Were you on hormone therapy ever in your life? Because knowing all that information really gives us, you know, an idea of when to look out for things. I'm like, listen, you really need to keep an eye on your blood pressure because it's going to start creeping up. Or if I already see cholesterol levels starting to go above the normal levels, got to change your diet. So the biggest, we see events in women, like cardiovascular events like heart attack and stroke, about 10 years after they hit menopause. So that's, we want to catch that early and know when that those levels are going down, and know that we need to be aggressive about modifying those risk factors at that point. Other things that we also, I wanted to just discuss, there's something that it's rare, but it does happen more commonly in women, is something called broken heart syndrome, or it's called Takotsubo cardiomyopathy. And that is also hormone related. It's a surge of catecholamines or fight or flight hormones that can actually cause the heart to expand, and the function decreases. There's been some famous actors, actresses. It does happen in men too, but it's definitely more common in women. But that's something also that women's bodies react differently to that surge of the catecholamines. So a lot of different cardiovascular disease. A lot of cardiovascular disease that is hormonal related, and that's really, really important to focus on.
Thank you for that. And it does raise the issue. I think you'd said to your, one of you had mentioned that, sometimes the main doctor that people see for their healthcare through women see through a major portion of their life is their OB/GYN, because they're interested in, birth control, and then they're childbearing, and then maybe they get into some perimenopausal issues and things like that. And it does raise the question of how much Dr. Joe finds herself, for instance, dealing with somebody's other health areas. So having to think about, I think you touched on a little, but how often, Joe, do you find yourself having to talk about general health with women and not just their sexual and reproductive health because of some of these tie-ins?
I would say all the time.
All the time.
Right. All the time. People, and I love what I do. People come in to talk to me about their sexual dysfunctions. They come in to talk to me about pregnancy issues. They come in to talk to me about anything that is OB/GYN, right? But they also come in and kind of expect that you are, like was said earlier, you are their doctor as this female is going to come to me, and I'm going to be kind of the primary care for that woman. And I tend to, through the years, what I've done, and it was a little bit different when I first started practicing, but through the years, you are only as good as your team, right? You have to have a good team around you. You have to have good referral people around you, and you have to know when to refer someone. I actually teach a course called culinary medicine at the medical college. And it's very interesting to me because when they came and asked me to teach it, I looked behind me and I said, wait, I'm an OB/GYN. Like, did you not know that I was an OB/GYN? Why are you asking me to teach this? But I think it's very interesting because it's lifestyle medicine. And I think that it was Dr. Sellers, right, that had talked a little bit about this. It is so important because everything we do in our lives is wrapped up into what we end up being as far as our health goes, how we prevent diseases from happening. Some we can prevent, some we can't. Dr. Milani, I'm sure, talks to her patients every day about modifiable versus non-modifiable things, right? There are some things we just can't change. Our hormone milieu is probably one of them, other than when we're taking exogenous hormone. But as far as, I think what I tell my patients is, I love that you only want to come to see me. I love that, but please don't do that. Because I really do feel that you need others, right? Absolutely a family practice doctor. Because if you break your arm, I'm going to send you to them anyhow, right? Your heart health. I used to joke with people who would call me and I'd say, I'm sorry, I'm below the belly button. Although I do examine breasts, but mostly, I take care of certain holes and certain parts of your body, and your ear is not one of them, right? I don't own an otoscope. I can't look in it. So there are reasons we all have specialties, right? And I want that person to be, if I'm not the best person to be taking care of someone for any particular reason, I am going to send them to who is the best person.
Which is another great segue. So I can bump it back around to Dr. Sellers too, and ask, do you feel like there is technology that can help people coordinate all of these different specialists or keep track of what all their doctors are saying, or, write down, the things that they're experiencing, which may be, some symptoms you may not know. I have patients that'll come and I'll say, oh, well, let's, see what your primary care thinks of this. And they'll say, oh, well, I don't go to primary care. I just go to specialists. And I think, well, how do you then know where your abdominal pain's coming from? Because, last I checked, that could be like a lot of different systems, So, I think that the primary care is the place where most of us go for the main portion of our diagnostics, when we have a symptom. So do you have advice for people, for women, about, sort of keeping track of all of this big mess, since you're one of us who's interested in use of technology and how that can help us?
Yeah, absolutely. I mean, health tracking in general, and just, we already talked about it earlier about how it's really important, to keep track of things. And when you come to your doctor to, have an idea of what's been going on, and you have an idea of, what you can talk about, tracking this or keeping a journal, I think is really important, especially, important for specialists and important in primary care as well. And we do it all the time, really. I mean, we ask patients who have high blood pressure, hey, write down check your blood pressure at home and write it down every day or every week, or, however often you have to be doing that, so that we can monitor the blood pressure and not go on, the blood pressure that we measure in the office after you were late, stuck in traffic and rushing to get here, and the blood pressure is through the roof, We do this for other things. We track sugar levels for diabetics. We ask them to check their glucose readings so that we can monitor their insulin regimens or whatnot. But it's also helpful in other aspects of primary care as well, and in diagnosis, for people that come in with other, common issues, whether it's that I'm getting migraines and I don't know why, or I have these weird allergies that come up, or I have a rash that comes and goes sometimes, and it's on my face and it's really annoying, but I don't know what's causing it. Well, the best way to address this is to, keep a diary, take every moment where something like that is happening and write down some things that are going on around that time. What did you eat prior to that? Or what, what other, things were you around, or where were you when it happened, to help, kind of look for patterns and things that can kind of, just help people make sense of what's going on, and potentially find a diagnosis for some of these things that are happening.
And for women, it's probably also helpful to keep some pretty decent track of their menstrual cycle.
Absolutely.
I think there's definitely a lot of symptoms that, ladies, correct me if I'm wrong or you disagree, but I think there are some things that can fluctuate even throughout the course of the month. I mean, you mentioned migraines, right? And that's definitely something that is very affected by women's hormones, much more prevalent in women, and, much more common to have, headaches either right before your period, right after your period, or and especially crazy, when we're going through hormonal changes. I don't know, Dr. Joe, you can address like early pregnancy, perimenopause, and menarche are times that I think have a lot more struggle with that. I certainly see that as part of my practice as an ENT, with people having a lot of facial pain and other related symptoms like vertigo. But I think keeping track of hormones can be something that's very useful. Do you agree? And then one of the other ones, which I really find as like a pet of mine that I find really interesting, is actually also weather. Do you guys see any changes with weather, like barometric shifts, things like that for women's symptoms? Anybody? I'm seeing nodding heads, but yeah.
I mean, I think it's a pretty common thing in the kind of autoimmune joint disease space that patients do find barometric pressure changes can exacerbate, make their symptoms worse.
It's so fascinating to me, because as far as we know, we really don't understand how our bodies sense the barometric pressure. There's no like sensor we've ever found in our body, but somehow our bodies know. And there are symptoms like headache and joint pain that are very, very known to have flare-ups when the barometer is shifting. And I think some even medical professionals might be like, that's not really a thing, but there's really some pretty decent data on it out there. And I think understanding those other secret, silent changes in your life can, if you track those things, like we'll say weather and menstrual cycle, as well as other things in your lifestyle, like you mentioned, Dr. Sellers, like, what you're eating, whether you're drinking alcohol, what your sleep is like, your stress level. These are all things that go into, creating your body's experience and can come out as symptoms, right? It can influence your symptoms. So I think it's interesting. I mean, we're obviously all fans of keeping track, but I wanted to get your guys' input too. Like, I know, now we have all these technologies, but do any of you in your earlier practice, or maybe still, have patients who come in with the notebook, with the binder, right? With the right? Those patients, yeah. And so I want our audience to know this is a thing. Like, people will like keep like a little spiral bound, or maybe like a folder. And I especially like the spiral bound because people will put the dates on there, and make notes like that. So we all feel that is actually really helpful, especially if it's fairly organized. We don't want like rambling pages of it, but it's hard to get through, and make sense of. But I think we all are saying that we really appreciate when people feel, take the onus on themselves to keep track of what's going on with them, and then also do some preparation in advance of the visit in terms of sorting through that information and trying to find some of their own insights that they can bring to their healthcare visits. I know we had wanted to talk about too, like, we're sort of talking about some chronic conditions here, and we've talked about, there's chronic conditions like, blood pressure and heart disease. And then there's other things that are chronic conditions like autoimmune that are harder to sort of pin down and explain and manage. So I want to bump to you, Dr. Schmerling, too. And, as we're getting on towards our time to have audience questions, if you had anything else you wanted people to know about chronic conditions in women in particular, maybe having to do with some of the things we've talked about.
Yeah, I mean, I think we did touch upon a couple of these things already, but I think, knowing that lots of diseases will happen in both men and women, but they often look different in women. And the way that we're trained to identify them is usually how they look in men. So you think about a heart attack, you think about a man clutching his chest, doubling over, sweating, all that stuff. Some women just feel a little bit nauseous, or they just feel a little short of breath. And, their symptoms can be a lot more mild, even if they're having just as serious of a heart attack. Same thing, autoimmune diseases are often called invisible illnesses. And it's because, patients might have a great day. So you as a provider, and I've been guilty of this myself, you have a patient who looks great in your office. Their vitals are great. Their exam's great. They're in a good mood. They look great. And then they tell you, like, this is actually the best day I've had in 2 months. I've been, not able to get out of bed for half of the last 30 days. And that is, I think a really important thing for you to be advocating as a patient is, that's why this tracking is so helpful. That's why finding a doctor that will listen to you is so important, because lots of the things that show up in women, sometimes the symptoms are actually really different, or can wax and wane and come and go. And so making sure that you are conveying that, and you're really, advocating for yourself if you do have a really great day that, maybe the last month hasn't been that great, and letting your team kind of figure out how to move forward from there.
And in terms of like how women, how women's symptoms have been sort of, I don't know, I think a lot of us have been taught a little bit wrong, right? Because there's been focus on what symptoms look like in men, how drugs work in men, and things like that. Do you guys want to comment on how we can sort of get the word out about focusing on women's symptoms in particular, and how they can advocate for themselves with regards to how their symptoms might look different? I mean, what do you think that people should do in terms of like thinking about their own, how am I saying this, about their own presentation? Because we know that women's symptoms may not be as recognized by healthcare providers, and there may be some unconscious bias, like you mentioned, in terms of trying to, put things on mental health issues, both with women, but also with people of color, and other minorities. We know from studies that women's reports of certain symptoms and also people of color's reports tend to go under recognized. So, maybe I'm answering my own question and saying like the more data, the better. But do you guys, is there any other thoughts that you have about how we can bring these symptoms that may be atypical to the view of our healthcare providers? Anyone can take it. I guess you're unmuted, Dr. Schmerling, so maybe you go first.
I think Dr. Kakady has been unmuting on and off, so I think she has something to say.
It's a struggle. And I think that one of the best things that's happening and that I think needs to happen more is for women to talk to other women, for people to talk to other people, right? We have all been through an incredibly stressful couple years. I don't know. I mean, maybe you guys do, but I don't know anybody who hasn't been stressed this last 2 years, right? And all of us and all of the audience, that stress is a huge part of our health and what happens with our health from a mental standpoint, from a physical standpoint, from a behavioral standpoint, from a metabolic standpoint, et cetera, et cetera. Every one of those hormones, since I'm hormone girl today, I feel like, our hormone milieu is constantly changing, but there is a significant difference when our bodies are in stress mode, right? And we've been there for two years almost, right? Whether you're stressed about what's happening in the government, whether you're stressed about COVID, whether you're stressed about people who've died in your family that you haven't even been able to go to a funeral for, there's just so many different things, dealing with death, dealing with all that we've dealt with the last 2 years. So as one of my final comments, I'll say, I think that we all need to be kind to each other. I think that we all need to just start looking at each other as the same as us. There should be no differentiation, no matter whether you're purple, blue, yellow, green, or red, or what gender you are, or how you identify. I just love everybody and be kind to everyone. I think that if our stress levels came down and we could get rid of somehow or alleviate some of the stress in our lives, find something to be your stress relief, no matter what that is, whether it's a person or going to lunch with the girls and talking about these symptoms that come up. I love when patients come in and say, I can't have an orgasm anymore. And I would never have told you about this, but I was at lunch with a couple of girlfriends the other day and somehow it came up and none of us do, right? I mean, that's wonderful because that's opened a door for us to have a conversation. And I'm sure that every other doctor on this panel thinks the same way. If you keep your symptom diary, as Dr. Sellers said, and you go to a doctor with it and they're overwhelmed by that, find someone else. Right? Find someone who's going to listen to you and who's going to take care of you and help you. And
yeah, you make a point
advice.
too. It's a good point. I mean, basically what you're saying is that, we all need support and, we should find healthcare providers who give us support. And we should find people in our lives to talk to about things and, also maybe even support groups, people who have chronic conditions. It's exhausting, right? And having people who are going through something that you're going through, even if they can't say, oh, here, take this pill and you'll be better, are going to help you, cope. So I think that's something that needs to be recognized, right? And I know Dr. Sellers and Dr. Schmerling are also both involved with telehealth. And I think that's a way too, that for patients to, let me know what you think, guys, but one thing about telehealth is it's quite accessible, right? So it's a way to get support, even if you feel like you can't leave the house.
Yeah, that's one of the things I love about telehealth because it's so easy for people to connect and see their physician. And, it's essentially that, that whole idea of bringing the doctor back into the home. It's kind of that because, right, we're seeing people at home, where they're living. And I think the other really great thing about using, various technologies to interact with patients is that you can also keep in touch with people through other modalities. If people, have difficulty figuring out the camera for the video or whatever it might be, you can text with them or you can do a phone call. And by taking out all the complications of going into the office and all of that, you just are able to interact directly with patients and more frequently, and having that kind of longitudinal contact, I think really helps, validate what the patient's going through. It helps give them support. And it's just really great for, contributing to overall health and well-being.
That's great. And I think I'm looking at the clock now, and I think I want to leave a little bit of time for some patient questions, some participation questions, I think. I actually do have some questions here from the audience. A great question that just came in, which actually I was kind of wondering about myself, was when in a woman's life should they really start seeing a cardiologist to discuss cardiovascular health? Is that something that, we should all do, or should we kind of wait for our primary care to send us, or how does that work?
I actually think definitely have a primary care doctor, but with any chronic disease, other chronic disease besides a cardiovascular disease, I think it is important to see a cardiologist, especially something, I think someone mentioned lupus. I think it is important just to have a one visit, make sure everything is normal, have a discussion, have a relationship. And, it's all about prevention, right? So don't end up at a cardiologist when something has already gone awry. You want to have that beforehand. So I think, cardiovascular disease starts showing up usually and kind of as you get older. So I think, in the 20s might be a little bit too early, as long as blood pressure is normal, cholesterol levels are normal, weight's normal. I think you can just be monitored by your primary doctor. But if things start to change, you have any symptoms, I think it would be worthwhile to maybe have a one-time visit with a cardiologist and establish a relationship.
And I'll just build on that too. I think the question was kind of specifically around autoimmune disease, which we know many autoimmune diseases do significantly increase your cardiovascular risk. And this is another great example of you advocating for yourself. Your primary care doctor might have a handful of patients with, your autoimmune disease, but they're taking care of all sorts of different patients. And, I think your screening and your intervention might be really different if your risk factors are higher. And so I think going in knowing, hey, I've had this diagnosis, I know my risk is higher. Is there anything else you think we should do today? And push your doctor on that. And, you may be somebody who gets their cholesterol checked before somebody else who doesn't have your autoimmune disease would have gotten theirs checked. And so ask those questions and, definitely question if you don't feel like the care that you're being given is appropriate.
Yeah. And so you would say for advice for most of us would be, let your other doctors be your guide, but when in doubt, go ahead and talk to Dr. Milani. Yeah. Okay. There's another question here that's interesting. And it basically, a person asks, are we integrating any sort of discussion of food ingredients and preparation into our practices? I mean, I think I know what Dr. Milani is going to say, because you guys are all about that Mediterranean diet these days, but I think we can just see if, and from an anti-inflammatory viewpoint, Dr. Schmerling and your work with autoimmune disease and other stuff. What do you guys have to say about food?
Yeah, I mean, I think Dr. Milani is going to have a lot to add here. And, at Isla Health, we have a nutritionist as part of our core care team. And I think the big part of that is really finding the foods that, work for you and your body. I think there's a lot of theories out there about which foods trigger what types of things. But I think the more we know, that every patient is different and unique. And so if you are finding that and when you eat a certain type of food, you're having certain responses that, maybe we find alternatives, but really with the goal of trying to include as much in your diet, eating a well-rounded diet as much as possible, whole foods as much as possible, and really sticking to kind of those, healthier, whole grain, less processed foods is in general, I would say, good advice.
Yeah, I mean, I totally agree. We know that processed foods typically have preservatives, which include that are high in sodium, and that contributes to hypertension and complications when there's a low heart function. But, I typically tell my patients fresh foods are the best. And then as far as the Mediterranean diet, that's really the only diet that's been proven to decrease events like such as heart attack and stroke. So that's diets that are high in omega-3s, like salmon, almonds, avocados, walnuts, things like that. So it's all about a well-rounded diet, including these types of foods.
And I would say, just on a primary care note as well, if your doctor doesn't ask you about diet and exercise and things like that, then ask your doctor what they think, so that you can, get started and have that discussion, from the very moment that you start with your annual exam.
I think a couple other questions that came up, we already kind of touched on, especially a person did ask if migraines were more common in perimenopause. I can tell you that that's a yes, just from my practice, but do you guys want to answer that patient's question?
Yeah, I mean, I think, pretty much any hormonal trigger can be related to menopause, or can be related to migraines. We know that those are very closely related for lots of women. That's not true for every woman. Some people have no association with their menstrual cycle or pregnancy or anything like that. But it is kind of a known time. But I will say, just as kind of my cautionary doctor hat, if it's the worst headache you've ever had in your life, you should be getting emergent care, and you should be talking to your doctor about this, because I think it is new onset headaches at any point in your life can be really concerning.
Yeah, absolutely. I mean, even though there's a lot of negative imaging that we do for headache, anytime that the headache pattern is strange or just different, it's worth looking. I mean, it's usually negative. So we want patients to be proactive, but not overly stressed about it. But yeah, it's always a fine line that you walk between, like, making sure that there's appropriate follow-up and not freaking out.
I think that this is kind of also where, like, keeping track of symptoms and things like that is so helpful, is that, how is this different from my norm? And I think we all have a gut instinct, and something is not right. That fatigue is not your normal fatigue from just like having a busy day or a busy week. That headache is, I have migraines, but this one's like a little bit different. So I think knowing that there's something that's off, and like going to your healthcare provider and being like, listen, I've had headaches in my life. I know there's migraines listed on my diagnosis, but this one's different. So I just think that that's so important.
And it's good for everyone to remember that. We also have a question that the patient asks, or person asks, that they says they're interested in older adults, and what role does mental health play in helping older, specifically women, deal with chronic disease. And I'm not sure that question is very broad, and it could mean a lot of things, but in my mind, it triggers, like, really in the geriatric population is, what can we do to help people with that interaction between, being chronically ill perhaps, and also, having some mental health. I know for me, just to answer from my point of view, I feel like I do see older people whose actually declining health is a factor in their depression. I know we talked a lot about, anxiety being a causer of symptoms, and also something that we blame for symptoms, but there is also that flip side of it, which is that, people who have been struggling with their bodies, that it can really wear you down. And we talked about getting support, from other people, support groups, and from your healthcare provider. But I think this question also raises an interesting aspect of really, if we should seek even, psychiatric care for just the mental health aspect of being a chronically sick person. You guys, what do you guys think about that?
I mean, from a cardiovascular perspective, I think that, mental health is so important, because having depression or anxiety does lead to, poor health choices sometimes, poor sleep, then that can contribute to weight gain and cardiovascular disease, and it kind of progresses, and then it's kind of a cycle. So other conditions develop, and then it's even harder on that person. So I think definitely addressing and mental health is so important, and guiding them to a therapist, not necessarily medications, but a combination of behavioral therapy and also medication might be. And this is where I would probably refer to a primary doctor who would be able to manage a lot of this stuff.
Yeah, and going along with that, I think it's really important in the primary care setting that there is someone as part of your care team that can provide those services, especially through therapy. If you decide not to pursue medication. And you're right, there's just so much back and forth between chronic conditions, worsening mental health state, which then can have a negative effect on the chronic condition. And it's a very difficult cycle to get out of. But it's not an impossible cycle. And I think that's really important for people to kind of believe, because, cognitive behavioral therapy works. It works on tons of things that you wouldn't even expect it to work on, like insomnia. I think it's really a tool that's underutilized, and I think at any age it can be extremely helpful for addressing some of these things.
Yeah. And I think, to kind of shift back a little bit to the geriatric population too, I think we see a couple things happen commonly in geriatrics. One is kind of grieving loss of function and loss of, mobility and things like that can be really challenging. And so I do, again, really echo the cognitive behavioral therapy piece of this, this is a reality. We know that our bodies get older and frailer as we get older. And how do we kind of process that and incorporate that into our life in a way that doesn't feel negative or overwhelming? And then the other thing I would just add to that, in the context of perimenopause, is a lot of the medications that we use to treat anxiety and depression have actually indications for perimenopausal symptoms too. And so again, finding a doctor that will listen to your whole story. They should be thinking about, how do we use the side effect profile of this medication to treat as many things as possible, so you're on as few meds as possible.
I think most women don't know that. I mean, I know that, like, for instance, low-dose Zoloft is used for hot flashes. And I remember speaking with an OB/GYN friend of mine who said that it's actually one of the best things that she's found. And, I think it's important for patients to understand too, that some of these medications, for instance, this particular thing, but also, the SSRIs in general, I know for some chronic vertigo syndromes, they're actually quite effective. And, we don't need to, we don't need to put a label even on saying, oh, we're using Zoloft, therefore we think you're crazy or, depressed or anxious. That serotonin has really very diverse ways that it interacts with our brain, and somehow these brainy type symptoms, like whether it's a hot flash or vertigo or a panic attack, that the SSRIs can do, or headache, can do very interesting things with our symptomatology without us having to label them as a mental health issue, right? It's like a gray area. I know you guys see that, right? I'm just an ENT doctor, help me out.
No, for sure. That's definitely right. And I use SSRIs all the time for things that you don't necessarily put a label on, or you can't really put a label on it. But I think it also is important that patients feel comfortable talking about this too, because if patients just chalk it up as like, oh, I'm perimenopausal, this is normal. Okay, maybe it's normal, but it's important to speak about that with your doctor, because symptoms like this can be very bothersome and actually very treatable as well. So just think that's important also.
I think if we could sum up something I think that we're all saying today, I think that is probably it, is sort of give yourself credit, write it down, keep track, bring it to your doctor, find people who are going to listen to you. And I think that's it might be actually just a perfect way to end. It's 1:30 now. So we've hit our time limit. But I really want to thank you guys for coming. Is there any last little last things that you guys want to add before we sign off? Anything?
I think just, keep advocating for yourself. I think, trust your body, you know it the best. We might all be specialists in our area, but you're specialists in your own body. So
It's a great point. It's a great point. And that's one of the things with, self-advocates with self-facing journal, like journal apps and things like that, where the patient can create their own story and bring it, to their healthcare provider. So I just want to thank you guys for all chatting today. It's been super fun. And, hopefully we'll do it again. We'll do it again some other time. All right.
Thanks so much.
Bye, everybody.
Thank you for having us. Thanks.
Bye-bye.
Bye.